Hi guys, it's Dr. Eric Lindquist, CEO and founder of SonoPath.com, and I'd like to invite you to pass through your surgical or commuting day in veterinary medicine by listening to our podcast, Real Talk in Veterinary Medicine, from experienced professionals who aren't afraid to tell you how things really are so you can optimize your veterinary career and your process. Hi guys, how you doing? We're here with SonoTalks. Dr. Eric Lindquist, I'm CEO of SonoPath and Real Talk in Veterinary Medicine, and we are here finally. We have my great friend Dr. Peter Modler. I call him the Austrian MacGyver of veterinary medicine. The guy could put together a Porsche with some GILU wire and a rubber tubing if need be. He's one of these guys that is Mr. Fix-It, and he does everything in veterinary medicine at a very, very high level. He's primarily a cardiologist, but also a cardiologist, surgeon, interventionalist, orthopedic surgeon on top of that, and he's a great sonographer on top of that, and he knows some pretty good medicine on top of that. So pretty much a very unique individual in veterinary medicine, and those of you that have heard Peter lecture or talk or hung out with him, you know what I'm talking about as far as what a great human being he is, and definitely a big asset to veterinary medicine, contributes to lots and lots of research, and he's very innovative, always pushing the envelope, so logically it fits in with what we do here at SonoPath within our capacity, and we're really happy to have him here. He's here with our doing our STEP Echo seminar, and we will have him as one of the primary cardiologists in our SonoPath Summit in July 10th through 12th in Santa Monica, California. So if you haven't seen any info on that, go to sonopath.com and take a look at that. Dr. Peter Modler represents Europe. Dr. Brian Scanson and Dr. Maggie Macon-Lamy are the three cardiologists, two from North America and one from Europe. So we have a friendly cardiology duel, so to speak, on the beach in Santa Monica. It's all oriented towards general practitioners to sonographers, anybody who wants to know what a beating heart's doing. So SonoPath Summit, July 10th through the 12th. And it's a great time to hang out with Peter, who's just a really great human being. And he flew in last night, so he's a little jet lagged, but I got some coffee into him. So we're going to have a conversation, some real talk. Peter, thanks for coming once again. How you doing today?
I'm doing great. Thanks for inviting me again.
Absolutely. And of course, Peter has the coolest accent in veterinary medicine. So Peter, we've known each other since 2011, if I'm not mistaken, ECVIM in Porto, Portugal, and you were just starting to get into cardiology at a high level in your industry. Tell me how you got there, and tell us what's happened ever since.
I think most of my career happened somehow incidentally. So I finished my study and did an internship in Vienna just because my wife wanted me to do an internship. This was the first thing. My boss, told me to do an internship. Then I applied for a job in Upper Austria, but the guy there who owned the hospital there needed a surgeon. So I had to specialize on orthopedic surgery first, and I did it and completed it, and I did a lot of surgery there, because at that time you were happy to have a job, and you just focused it on what your boss wanted you to focus on, right? Then I had to move to northern Germany because my wife wanted to work in a horse hospital there. And there was also a small animal hospital, and they required a cardiologist. So I had to specialize in cardiology. And
orthopedics to cardiology, you're killing me, Peter.
So I did that, and finally I passed the board exam of the German College of Cardiology and met a lot of people, of course. And after this, it was so funny. I met one of the most renowned German cardiologists, and I talked to him and said, okay, I would like to work on open heart surgery and to work on mitral valves. And he told me, this cannot be done. And I said, okay, this is a very good motivation for me to do it.
Right.
And And again, I had people supporting me, my wife at home, because I brought hearts at home, from pigs, and to work at it and trying to fix the valves. She opened opened up the heart on the kitchen table, and I tried to do my first sutures inside.
That's definitely true love there, Peter.
Yeah,
when your wife lets you cut up pig hearts on the kitchen table,
it is.
That's a good one.
And luckily, my former partner also supported me with this, and I always get bored when I'm doing the same thing all the time. So I have to find something else to work on. And one of my most important mentors is Dr. Eric Lindquist, of course, and he keeps motivating me all the time.
You don't need me to motivate you, Peter.
I'm very lucky that we met in 2011 by incident, by the way.
Yeah. Or we had a common friend that sat down and had some lunch, and he didn't speak English very well. He's one of your good colleagues, and so you became translator. And then in the end, the conversation became us, and then that's when I was just starting SonoPath from the beginning, and I said, "Hey, Peter, by chance, do you have a cardiology archive you're interested in helping me with?" And that was one of the first moments of the beginnings of SonoPath. It was a great one in Porto, which is a wonderful city.
Yeah.
So tell me, so as you move forward, and tell me what you're doing now, and tell me how you got into the mitral correction surgery specifically. I know you've worked with Weichi, of course, and Dan Brockman and some other people, but tell me what your day's been like over the last few years now.
Yeah. 10 years ago, I bought into the hospital that I'm now owning, and it has grown ever since. And it's now one of I would say it's the biggest hospital in Austria, the biggest referral hospital. And the caseload of cardiology increased, and then we started doing interventions, and the caseload increased further and further. And we saw a lot of mitral valves, of course, as everyone does who's doing echoes, right? And then I thought, okay, it would be an option. Would it be possible to correct mitral valves? And I have a good network, and one of the human cardiac surgeons, he was happy to help me at the beginning, just to tell me some important things, because I mean, nobody in veterinary medicine is able to or is used to work on a tissue like a heart. It's completely different from all the other tissues that you're usually operating on. There is no connective tissue on top, for instance. If you do suturing in the heart, it's completely different. And the second thing, what I found out, is you can't correct the mitral valve in a dog like you do it in a human being. If you do it, the dog will die. So it's completely different. And so, of course, it was some learning curve, and I had also dogs dying at the beginning, of course. And then by incident, again, I met Professor Brockman, and we became friends, and he wanted to start the mitral valve program in the United Kingdom as well. He was already doing some cardiac surgeries, but not mitral valves. And he came over to my place a lot of times, and we practiced a lot, and then we did all the first surgeries together. So he came to Austria, or I came to London. Sometimes the owner had to pay for the flights. It was funny, somehow. And luckily we were successful finally. But it's very demanding, of course, in terms of personal thing. You need a lot of people to help you to do all the aftercare. But it was a very interesting learning curve. And now we're doing not only mitral valves, we're doing right heart surgeries, we're doing a lot of different things. And it's extremely interesting, right? And as I told you, after having done mitral valves for years, it's getting boring.
This is the kind of guy that Peter is. He's bored doing mitral valve correction surgeries.
I had to find something new to work on.
I need something new to work on.
And I was very lucky that Masami Ushi from Japan, he was really happy to help me, and to support me. He supported me like he supported no one else. Yeah. So if I had a question, he gave me an answer immediately. I could call him at any time. Yeah. If I needed material, especially the small cannulas. If you work on small dogs, cannulas for the heart-lung machine for small dogs are not available in Germany or Austria.
Yeah.
So he sent them over to me.
Oh,
He didn't
nice.
send them over to England, but he sent them over to me. Yeah.
Well, Dan's got to friendly up a bit more with Masama, I think. I've heard Masama's a really wonderful guy. I haven't had the pleasure of meeting him, but
Very funny guy, by the way.
Yeah. That's great. That's That's
so
awesome.
that's the history of mitral valve surgery.
Yeah.
But
between the mitral valve surgery, you're cutting backs, you're cutting hips, you're cutting pretty much anything that needs a scalpel, right? So Monday through Friday, what does your clinical work look like? What does your clinical work week look like?
Nowadays, I would say it's 20% administration. Unfortunately,
administration. No. We don't want to talk about that.
There's
other types of real talk when you talk administration.
Everything that exceeds my 60-hour working week. It's administration.
That's administration.
It's about, I would say nowadays it's about 70% cardiology and ultrasound and 30% surgery. I love to be on call during weekends and nights. Even though it's a lot of work, but
sure.
All the emergency surgeries occur after hours, right?
Sure.
And I like to do spines, I like to do fractures or diaphragms or what else,
Sure.
So I would not give this up, And one of the beauty of veterinary medicine is that you can do so many different things, It's not like in human medicine. If you're a shoulder specialist, you're doing shoulders all the time, And at some point, I think you get crazy,
Right.
And if I'm bored by doing mitral valve ultrasounds, then I do a few more spines, and that's okay, And many years ago, one of my best friends said, okay, you have to decide what your specialty is, because otherwise no one would take you seriously.
Right.
I'm so happy that you still do.
I do. Well, I don't, but I fake it. We have a lot of fun, Peter. It's nobody's. I mean, Dr. Ken Leal. I mean, he's the general practitioner version of what you do as a specialist, because he's done everything. And when I was a general practitioner, I was in an area where I could do pretty much everything as well, so you get to be a very good surgeon at that time. And then it's nice being in that semi-remote atmosphere, and you're in a specialty atmosphere in Austria, so you still get to do everything, which is great. But in the United States, it's really tough now to be able to have the geographical and social situation where you can still do those surgeries without having to refer everything out. And I think it creates a lot of challenges for those that want to really spread their wings as practitioners, right?
This is something that I enjoy about Austria especially. It's also getting changed in some countries in Europe as well, but not in Austria now. So I can still do everything. I have something like the IVUSS in Austria. It's called Facharzt für Kleintiere. It's almost similar. So if you have that, you're pretty safe.
Right.
And secondly, I mean, especially in shunts, there's a high demand on shunt surgery. I learned scanning shunts from you, and I see them all the time, and I think I do one shunt a week, surgically, and so nobody has this caseload in Austria.
Right.
So even though I'm not an internist, they send it to me because I find it and they can operate it. And if the rumor spreads, doesn't matter.
Word of mouth is the best advertising, absolutely. Because everybody wants the same positive results, and that's the one thing I do miss just doing sonography is the surgery, because it's satisfying when you see the lesion, you can cut the lesion, and then you can watch everything go the right direction. So the completion is nice when you've been a surgeon and a sonographer, and then you just go one or the other. There's always there's something missing. But I think
and it's good if you're able to scan the patient yourself before you do the surgery. I want in every patient with a need of an abdominal surgery, I want to do the scan by myself before I go into the surgical theater, because it gives me a good estimate of what I'm going to do.
Sure, of course.
And this helps me a lot. We have so many ultrasound units in our hospital, and there's always one in the surgery unit. Helps me really a lot.
Do you do a lot of intraoperative ultrasound?
Yes, I would say every now and then. So if you have to cut out, for instance, something that looks like lymphoma in a cat, it's very good to know where the submucosa has a normal structure again. To know where to cut, for instance, this is one of the main applications. If you have a foreign body somewhere in the lumbar spine, in the muscles, and you want to find it, it's good to have an ultrasound, right? Sometimes also, I had a couple of cases where a OCD lesion disappeared in the tendon sheath of the biceps.
Oh, really?
And it's very good to have an ultrasound there to know where it is, because you have to cut it out. So that's I think amazing. Over the past month, there's 3 or 4 cases of this.
I think it's such an underutilized modality as intraoperative ultrasound. Because
it is. Because most people are not able to do it. So if you're a board certified surgeon, most of them are not able to turn on an ultrasound machine.
Where's the button?
Some are, but not everybody is. So and then they call me in, and I have to do the ultrasound.
But you want to do the surgery too, right?
At the end, I end up doing the surgery.
That's funny.
But I love this kind of stuff, because these are cases that nobody has. And I always want to turn things around. To find new things. This is one of my main motivation, to do things that nobody wants to do. To break with conventions. This is something that's really interesting. We've just a couple of projects going on, finding out that conventions, generally accepted conventions, are wrong. And this is really interesting about my job or what I'm doing.
Well, I think that's very true in veterinary medicine, because we all love studies. Studies are great, and studies you can tear apart or you can support whichever way, and we all know that if you're in the research and it's like, well, this has this defect, this has that defect, but the bottom line is it's the research in veterinary medicine, that what we know in veterinary medicine is based on such micro populations. What we would call a big study is barely even a pilot study in the human side, right?
We're talking about evidence-based.
And we have all these, you're talking about Chihuahua to Great Dane and everything in between, and what's a normal, and from adrenals to chamber sizes to there's so much space in between, and that's where the fun is to play, right?
It is, and this is. But we still have room for new findings. We have room for new inventions. And this is the good thing about it. So we are able to turn things around.
Right. And this is one of the things one of the reasons that we thought of coming up with the cardiology summit in July, because we want to push the envelope on the concepts of cardiology, right? There's the consensus statements, and there's this what you're supposed to do, and there's heart failure has to have wet lung. Well, no, heart failure doesn't have to have wet lung. And what is there a B2 plus, which we know there's a B2 plus, and we know there's research coming out that's going to support the B2 plus concept, as opposed to B and C. There's a B2 plus there, and so we're going to address those sort of things. But you and I live in that territory all the time, or do we call it B2 plus? Do we put it on a report that says B2 plus or not?
And this is what I always say: if you want to lecture and tell people something that they're really interested in, you have to see these patients all day long.
Absolutely.
Because otherwise, you don't tell them the truth.
Sure.
And regarding studies, if you look into what we call evidence base in a detailed way, you always find out that there are shortcomings all over the place. And in the end, you have to be very cautious interpreting things. Many studies in cardiology are based on heart failure. And heart failure is based on X-rays, right? So is X-ray a gold standard for diagnosing heart failure? It wouldn't be in human medicine, but it is in veterinary medicine. But I think, it's somehow dangerous.
Right. Well, now you have an interesting perspective, because obviously your history, but on top of it, you're doing a lot of work on cardiac CT, which is, completely changes the whole thinking process. And so when you're sitting in that little CT bubble, And now that we're doing a lot of CT, and I'm saying, now I don't know anything, because we're seeing everything in a completely different fashion, whereas the general population is still working on, it's not wet lung, so it's not heart failure, which, is not necessarily reality anymore. And so those are interesting things. A lot of people don't know what to do with those kind of perceptions of experience.
It was so funny how did I start with doing heart CTs, cardiac CTs? It was just an incident, by the way.
That's your life. It's all about it's all incidental, right? Something happens and becomes a cardiologist. Something happens and becomes an orthopedic surgeon.
My wife, I invited her girlfriend, her friend. I invited her friend to fly with me on the plane, and she sent her friend, which is now my wife.
So you're married by an incidental situation. That's funny.
And our CT, where the 16 slice CT, had a problem with the tube. So I had to exchange it. And the company came and said, we've got a refurbished 64 slice CT, able to do cardiac CT. Do you want to have this machine or not? And my partner said, what do you think? And I said, yes.
New toy.
Said, does it pay off? It's very expensive. Will you really use it? And I think, yes, I think so. And he said, you're always focused. When you're focused on something, at the end it was successful. So you can have this machine. And I got this machine and I started doing it, and I found out about things that I've never seen before. And then this machine had to be replaced, and we've got now an 80 slice cardiac CT scanner, and I'm doing, I would say, 2 cardiac CTs a week. So we've got quite a high caseload, and found out about so many new things. And 2 months ago, I gave a lecture at the Royal Vet College, a webinar about cardiac CT, and had a great opportunity to discuss cardiac CTs with these specialists, and it was really amazing. And I'm really looking forward to meeting Brian Skansen, because he's also doing cardiac CTs. He's also one of his main interests, and to share experiences. And in my opinion, I wouldn't do any congenital correction anymore without the cardiac CT. I wouldn't do it because you're missing so many details that you miss on echo, and that changes things. So and change your decision making.
Right.
So it's extremely useful. I like doing it. I learned many things. And I'm very happy to have this machine.
That's a new toy.
It's
accidental toy. That's fantastic, Peter. So you're board of German Board of Cardiology. So tell me how that historically looks up against ECVIM and ACVIM Board of Cardiology, and how are those entities formed? And I think there's a lot of confusion out there about that, and we've run into that over the years. I mean, similar to what I've run into at ABVP, and we're boarded just like surgeons and all the rest of it, and so there's always this misconception out there, and I think we've had that commonality of misconceptions about our board certifications over the years that we've talked about. So
basically, there's a big difference between the ACVM and ECVM, or the American Board of Veterinary Specialization and the European one, because the European one is just a private organization. It's not legally accepted. So it's just a private association, but a very good one.
Right, of course.
So the level of the diplomates is very, very high. And it's, of course, is respected in the veterinary field, but the owners have no idea what a diplomate is.
Right.
In Europe, we have national specializations, like America as well. It's a national thing. Of course, it's a German title in Austria that you get. And these are legally accepted. So if you're a specialist, if you are a European diplomate, you're not allowed to call yourself a specialist.
Interesting.
So you have to be a Fachtierarzt, for instance, so ABVP, like in Austria, to be able to call yourself a specialist. So this is the first thing. Then we got this German College of Cardiology, and German College of Cardiology evolved from the necessity of having standardized cardiac exams for breeding animals, over Europe. First over Germany, then over Europe. And the CC, or German College of Cardiology, was the first association publishing a standardized protocol for examining breeding animals, which is very good. And it's now, if you want to pass the exam, you have to prove that you're able to scan. You have a practical exam that's a big difference to ECVIM. You've got a practical exam that's very hard to get through. So you get a couple of animals with congenital heart disease, and you've got, I think, 15 minutes for the exam, including the report per animal.
Wow.
And when I did my exam, I think I had 30 pages of ECG to read, and so it was very hard. And you get a theoretical exam. The good thing is you can do it while you're practicing, so you don't have to do a residency. So the residency is more scientifically oriented, the CC is more practically oriented. But in Europe now, because the CC is now international, the CC is equal or just comes after ECVIM, and stands. It's in the veterinary community. It's respected more than the national titles.
Interesting.
So it's quite a good qualification, I think.
Right.
And also in abroad, they get to know about the CT now, and they respect it.
Right. Well, Peter, you're an extremely well-rounded and brilliantly intelligent individual that I've been very, very happy and pleased to know, and you're a great friend, and thank you so much for coming and talking real talk on SonoTalks with us. We've had a lot of fun this season doing it, and I'm so glad we were able to finally get you on here, and looking forward to the summit. The summit's going to be a blast, a lot of fun, a lot of cognitive and a lot of cognitive fun, and a lot of downtime, and it'd be nice hanging out with you and your family once again.
Yeah, the same with me, and I really appreciate your friendship. I really love to come to the States twice a year at least. It's really great fun for me, and I always keep saying, if there was just one CE event that I was allowed to lecture at, I would do it with SonoPath. So
thank you so much. Thank you for the plug. I appreciate that. Great, guys. Well, thanks again for joining us here at SonoTalks. Hope you enjoyed the time with Dr. Peter Modler, and have a wonderful day, and look forward to doing our next episode.